So we thought we were all very organized until 3 weeks ago, and we were in another palace where we have been many times. But the mayor of Palermo said he needed it, and so we had nowhere to go. But fortunately, we know a very good ice cream man who you will perhaps meet later. And being the ice cream man, he is very popular and he knows everybody. So he knows the lady who is in charge of conferences here. So we are here by virtue of Mr. Franco, our local ice cream man, and the representatives of the state. So it's wonderful to be here. And so I'm going to start. Sorry, Marta. Okay.
The battery of the main microphone.
So can I also welcome people online. I know that there are people from all across the world, including Japan. I hate to think what time of day it is in Japan. I think it must be in the evening. So I hope our Japanese colleagues will stay with us into the early hours of the morning. And of course, you can also, the lectures will be recorded, so everybody here and also on streaming can go onto the recording and with the link provided and see the lectures. So it's very nice to meet old friends here and old friends around the world. Dr. Takai Nori in Japan, I hope you're here, and very nice that you signed up. So I will start by talking. I was going to talk about from chlorpromazine to clozapine, but now a new thing has happened in psychosis, and we have a new drug which is about to be approved by the FDA in September, we hope. So if I can find, here we are. Sorry, we are just finding our way. So my first exposure to psychiatry was as a medical student in the 1960s. And this is a hospital called Leveron. Here. So this was a big asylum that had about 1,500 people there. And as a medical student, we were allowed to live there for free and to have, we were fed, we got a white coat, we were treated as doctors. And we did physical examinations on the patients who were there. They were there chronically. Many of them had been there for 20 or more years. And here, these are the ladies from a ward called Lomond Ward. The wards were either called after mountains or after valleys, and the mountains were for men, and the ladies were, their wards were valleys. So they were after Loch Lomond Ward. And you can see me on the extreme right. No, your left. You can see I've hardly changed at all. And next to me was my girlfriend at the time, first wife later, And she was an occupational therapist and very enthusiastic. And her boss, the head of occupational therapy, got married. And so they decided to invite the ladies who were called chronic patients, who had been in the hospital for very many years, to go to the wedding. And of course, so they're all dressed up in their best here. And of course, the bride's mother was very alarmed about this, bringing 15 psychotic patients to the wedding. She thought they would really disturb it, but they actually behaved better than the other guests. Some of the other guests got a bit drunk, it being Scotland, but the patients, they didn't at all. And so in these days, there were some nice bits about mental hospitals, as well as some very bad things about them. But you can see, I hope you can see that if you look at their hands, you'll see that they're all getting large doses of antipsychotic. And you can see the pill rolling movements of their hands. You can see here and here that very large doses of antipsychotic. So we have moved on from there. I should say that I'm very happy if people want to interrupt or ask questions as we go along. And also, will somebody keep an eye on the chat? And the people who are streaming might like to ask questions on the chat. Can you do that, Laura? Yeah. So this is 1970 actually. It was a successful wedding. But of course, things have changed, and one of the reasons they have changed, the clue is in this picture. So why am I showing this picture? What kind of dressing is this? Dopamine dressing, yes. Are you all familiar with this? That in the time of COVID, everybody was at home and not buying any fashion. So we were all miserable, but the fashion industry especially, because everybody was buying tracksuits and jumper suits and nothing. So they were very depressed, and lots of us were very depressed. And they said, after the end of COVID, we must do something to cheer everybody up. We will have bright clothes. And the fashion people, of course, are very clever. So some very clever person in fashion said, these are rewarding clothes. So dopamine is involved in reward. So there's an article here in the Huffington Post from last year, the science and styles behind dopamine dressing. If Huffington Post is too sophisticated for you, it's also, it became very, very popular on TikTok. So everybody in the fashion industry knew about dopamine. So we need to know a little bit about dopamine as well. So, of course, the story goes back to 1952 when the French introduced chlorpromazine for the treatment of psychosis. And the people who get the credit generally are Delay and Denneker. Delay on the left and Denneker in the middle. But the person who really had the idea was actually not a psychiatrist, but a surgeon called Henri Labarré. And he was looking for pre-meds to calm down his patients when they were going to have an anesthetic. And he found that antihistamines were helpful. So he went to the drug company and said, could you make an antihistamine, which is especially sedative? So they used promazine as the sedative. So they added a chlorine, so it became a chlorpromazine. And he also called it Largactil because of its large number of actions. Now, Pierre Denneker did the trial, famous trial. What did Delay have to do with it? Not a lot. Delay was the head of department. And in France at that time, if you were the head of the department, you were the first author on the paper. So here we are, 70 years later, we're still talking about DeLay and Denneker, although his main contribution was to be the head of department. He actually was quite an authoritarian man. He was very marvelous in many ways. He was a little authoritarian. And in the French, remember in 1968, the French students went on strike because they said the University of Paris was too authoritarian. And the one person they wanted to get rid of was Jean Delay, because he was thought to be the epitome of the authoritarian university. And they had a strike, and eventually he resigned, actually, in 1968. So anyway, they all introduced antipsychotics, and of course it was a team effort, and advances are always a team effort. And I know that because often I get the credit for things that other people in my department have done. So this is Arvid Carlsson, who received the Nobel Prize for his work on dopamine. He died a couple of years ago. This is him. He gave a lecture when he got the prize, a Nobel Prize, on the origins of discovering dopamine. So he was a Swedish researcher, and he came to I think it was the European College of Neuropharmacology, which was meeting in London, and he presented a paper on the biochemistry and possible functions of dopamine and noradrenaline in the brain. And the chairman of his session was a very senior British pharmacologist who said, well, I don't know if dopamine exists, but certainly L-Dopa is a poison and should not be given to human beings, and was very rude about Carlsson's paper. So Carlsson was very upset about this, and he said, I went home with my tail between my legs. And in 2008, when he was giving this lecture on the origins of dopamine, you could see that he still hated Sir Henry Dale after all these years. He still felt angry. So there is a lesson in this for people like me who are getting older. We should always be in favor of new things, not say that on balance, welcome the new rather than object to it. So I went home and he worked more, and Carlsson, a Lundqvist, in 1963, showed that neuroleptics, what we now call antipsychotics, block catecholamine receptors in the brain. And this paved the way for the dopamine hypothesis. And this was set out by Jacques von Rossum in 1966. When the hypothesis of dopamine blockade by neuroleptic agents can be further substantiated, it may have far-going consequences for the pathophysiology of schizophrenia. Overstimulation of dopamine receptors could then be part of the etiology. Obviously, such an overstimulation might be caused by overproduction of dopamine. Very modern, would still be acceptable hypothesis in the present day. And I started in psychiatry in 1972, and I never heard anything about dopamine. I went through my entire basic training until 1976, and that was the first time anybody mentioned dopamine to me. So although there was the theory, it was not widely accepted. But now we know that the problem in psychosis is that we used to think that it might be in the dopamine receptor, but it's in the dopamine in the presynaptic neuron, and the presynaptic neuron produces too much dopamine, and this is then released and hits the D2 receptor and causes psychosis, and we use antipsychotics to block that and to improve the psychosis. So of course, this is just the mechanism. This is the proximal cause. It's not the distal cause are the risk factors, and we come on to what these risk factors are. But this is the final common pathway to psychosis. And I guess many of you spend your days prescribing antipsychotics. And essentially, we have about 60 antipsychotics available, but they all do the same thing. They either fully or partially block dopamine. So I would be quite interested to know in different countries which is the most popular antipsychotic. Shall I start with Australians? Because I think our biggest group of people, not for the first time, are Australians, and we're very pleased. Yeah. Thank you for coming. So, in Australia, which is the most popularly prescribed antipsychotic, for good or bad? Can you agree? What are the most... Sorry? Clozapine, right. So, we know in old age, but what about your colleagues? Are they all mute? Clozapine also? Gosh. Yes. So I guess if you're running an acute ward for people who are very psychotic, I'm not sure the nurses will thank you for prescribing Clozapine. But certainly Clozapine is popular. Olanzapine, in Britain, olanzapine is still the most popular antipsychotic, although we know that there's a big problem with it. And then risperidone, and then the other one in the UK, I guess, is aripiprazole. But there are a whole range, and essentially they're different in terms of their side effects, but not different in terms of the site of action, which is the dopamine receptor, which until 15 years ago was blockade of the D2 receptor, but now there's also we also have aripiprazole and cariprazine, and we don't have. Do people have access to brexpiprazole? You see, in Britain we had Brexit, and that means we can't get brexpiprazole for some bizarre reason that we don't get it. Whoa! I said something rude. There we go. So until this year, this was the only mechanism of action of antipsychotics. But this year, something new has happened. And essentially, there are drugs called muscarinic agonists. And the neurochemistry is not simple, but essentially, they're cholinergic muscarinic agonists, and they impact on GABA, and GABA inhibits the release of dopamine. The dopamine release goes down, and dopamine production goes down. So instead of blocking the receptor, this is a means to actually diminish the synthesis and release of dopamine, which in some ways is more physiological. So you have less dopamine synthesis capacity, and you have less dopamine release, and therefore you don't. Oops, it's gone again. We don't need to block the receptors because there's not so much dopamine. But this was discovered in Eli Lilly in the 1990s, and they found that the problem was that this drug and similar drugs caused intolerable gastrointestinal side effects. So although they found it was a drug for Alzheimer's disease, and it didn't have very good, very strong they found that the people who also psychosis, that their psychosis improved. So they thought of trying it as an antipsychotic, but the side effects were just too unpleasant: gastrointestinal, constipation, vomiting, nausea. But there was a very clever man whose name is Steve Paul. Steve Paul, by accident, I shared a room with him in 1976 when I went to Bethesda in the United States. And there were three of us in the room. We didn't speak a lot because he was a pharmacologist. He didn't seem to understand a lot about the clinical aspects, which I was more interested in. But I never heard any more from him or about him until I discovered that he had founded his own company. And he did a very clever thing. He said, well, this drug, xanomeline, is a muscarinic cholinergic agonist, but it causes these nasty GI symptoms. So why don't we give a peripheral blocker which doesn't cross the blood-brain barrier, so it will block the cholinergic effects in the periphery, and the GI symptoms will be blocked, but it will not block the effects in the brain, which was a very clever idea. So he developed this drug, which is xanomeline plus trospium, which is called CAR-XT. And this is just to show the phase 2 study. And you can see here, this is PANS positive, the placebo, not much effect. And you can see CAR-XT with the psychosis coming down. And now they have done a much bigger trial of phase 3, and it's still effective. And we expect that this drug will be given approval by the FDA this September. Now, my roommate from 1976, who founded this company, has just sold it to BMS for $13 billion. So I was thinking of phoning him up and saying, remember me, we were very good friends. Oh, but sadly we were. But just amazing. So this, it still has some gastrointestinal side effects, but most of them are diminished. So, Samir, is it your bet it'll be a great success? So there's already 3 phase 3 trials. But would you put your money into the company, or it's BMS now, isn't it? So the question is, will we be prescribing this instead of our D2 blockers in the future? And I think we may well be doing that. So the next question, of course, is, it's still having an effect on dopamine. It's just diminishing the dopamine rather than blocking it. So we've known since the 1960s that dopamine was important, but why does having too much dopamine in your striatum make you think that the CIA are putting a chip in your brain, or that the man down the road from you is sending telepathic signals to try and make your brain not work, or that your parents are poisoning you? What is the connection between striatal dopamine and delusions and hallucinations? And much of what we know about this has come out from studies of prediction error. Are people familiar with prediction error? Some people will be familiar with it. So we go about our life, and we learn things and we predict. So this morning you all knew from the numerous emails from Marta that you needed to have a jacket and tie, or the prediction would be that you would be turned away unless you had a jacket and tie. And then you come up here and you predict that you'll get a lecture from an elderly Scotsman. I don't think you predicted I'd be wearing a kilt, actually. So that is a prediction error. So you might have released dopamine. You think, whoa, is he transgender? What is happening? So when you're surprised, you release dopamine. So dopamine, lots of animal stuff from a very brilliant man called Schultz, and showing that when mice are surprised, this activates their dopamine neurons. So I think there is a lottery. Pepe, is there a lottery in Italy? A lottery where you put money in and you might win? Is there such a thing? Does your mum, does she try the lottery? No. What about Laura? Does she do it? No, they're all too. Oh, they might have a friend who did the lottery, but not. Anyway, you're watching Italian television and thinking you've wasted your money, and your number comes up. Wow, dopamine. You release dopamine. But also, you're watching television and you see that there is a flood in Brisbane, and that your house is say, been flooded, or that there's some terrible thing has happened in Croatia. So when good things happen, when bad things happen, surprisingly, you release dopamine. So the dopamine firing facilitates our learning from experience, so that a particular event is remembered with enhanced value. When something new happens, you need to learn that this is possible. And so let me give you an example of this. Dopamine. Dopamine. No dopamine. Dopamine. No dopamine. So, yes, right. Anyway, point that in 5 years' time, and people say, did you ever go to that conference in Palermo that you were thinking about? Yes, it was very interesting. What were the lectures about? No idea. But there was this old Scottish guy in a kilt who showed pictures of pink elephants. That may be what you remember that day. So surprising things. And because you're in a state of heightened dopamine salience, this is imprinted on your memory. So it's much more difficult to get rid of than a normal memory. So dopamine is the wind of psychotic fire, and unmedicated patients with early psychosis show increased striatal dopamine and prediction error abnormalities. The increased dopamine signaling leads to aberrant assignment of importance to unimportant stimuli, and way back 30 years ago, a very clever psychologist called Geoffrey Gray said, if you're having too much dopamine in your striatum, this makes you connect things of no consequence. So meaningful connections are created between temporary, coincident, external impressions. So the way somebody looks at you, or the color of their jersey, or the way the birds are singing, they seem to be terribly important. And if you're thinking about your brother-in-law, or you're thinking about what food you're having, sometimes these things can be connected because of the force of the dopaminergic salience. So these may be connected perceptions with thoughts that happen to be present, or events and recollections happening to occur in consciousness at the same time. So you can have we have a system in psychosis. I will talk a lot about psychosis, and you'll wonder, am I talking about schizophrenia or talking about psychosis? So I don't regard schizophrenia as anything special. Schizophrenia is just severe psychosis, which doesn't go away readily. It's like going from overweight to obese. It's a question of degree, or from a high blood pressure to malignant high blood pressure. But factors for this are the same as the risk factors for schizophrenia. So people would have a sensitized dopamine system, then maybe acute stress, which we know can increase dopamine, or drug abuse, which we know can increase dopamine. This results in dopamine release. This causes the aberrant salience, the aberrant processing of stimuli. Everything outside looks very intense and different and loud, and seems to have great meaning. And you wonder, is it meaning of good or bad? And that depends on your interpretation. If you've had an adverse childhood with neglect or abuse, or been a migrant and been discriminated against, then you may learn to blame other people. Other people are against me. So when strange things happen in your environment, you may blame these strange occurrences on people out to get you. So you become paranoid. Once you're paranoid, then this causes a lot of stress. if you think that your best friend or your husband is poisoning you, or you think that, here you are in Palermo, or that the mafia will be out to get you, that you are very stressed by this. So you're even more stressed. You may barricade yourself in your house and threaten the neighbors, that the neighbors are threatening you. You may get a knife or even a gun in some countries and go out and wave it about and tell the neighbors to behave better. At this point, one of you, I think, would be called, or maybe the police would be called first of all, but then one of you would be called, and you would have to persuade this man, usually a man, say, "Oh, hello, Mr. Brown, remember me? I'm the doctor from that very nice hospital." And we say, "From the nice Maudsley Hospital." "The Maudsley Hospital, that's a terrible place. I'm never going to have anything to do with that place again. But Mr. Brown, I think you really do need to come into hospital." I'm not coming. "Well, I'm afraid if you're not able to come, we'll have to ask my friends, the police, to help you to come." So then there's a struggle. The man is even more stressed. He comes to the hospital, and there he meets some nice nurses who say, "Oh, Mr. Brown, I'm sorry you've had to come back to the hospital again. But don't worry, we'll give you an injection to calm you down." "An injection? I don't want an injection. I know you're really going to kill me with this." So this, of course, results in more psychotic beliefs and more stress. And so the patient actually gets worse from the intervention that we have tried to make. Erika, you're explaining that this does happen in Italy or not? How do you persuade people to come to hospital in Palermo? With the police? So there is a mental health act, and if somebody in Palermo refuses to come to hospital, you try to get the family to. Yeah. So, Diego, sorry. Sorry, hang on a minute, Diego. This is Professor Quattroni, who is the new professor of psychiatry in Palermo.
Okay. In Italy, what helps is having a strong family support. So sometimes they are able to avoid the mental health act because there is a strong family support that somewhat is able to persuade the patient to come on their own wish to the hospital.
It's not their wish, but in southern Italy, la mamma is more persuasive. The mother is more persuasive than the police. So she says, "You're not getting any nice pasta. I'm not going to feed you. You have to go to the hospital."
In Sicily, mother is more power than police, and I'm scared more of my mom than of policeman. He can say something about this.
Yes, we have. Pepe, are you more frightened of the police?
Yes.
Yes. There we go. She looks innocent enough, but so obviously, different countries, it is different. And one of the great things about southern Italy and southern Spain that we'll come to is the coherence of families. In London, many people with psychosis live alone, and they are brought by the police, which of course makes everything worse. So usually we try and decrease the stress, or people using drugs. We block dopamine, or in the future we may be able to diminish the release of dopamine. We do CBT to try and alter the cognitive schema and get to understand that these strange things that are happening, that they may not be of the sea or Marta. I should be behind the... Okay, right. Sorry. So apologies to those of you online. We're just getting used to the system. So the CBT or some other psychological approach, and nowadays we have some new psychological therapies such as avatar therapy. And in the majority of cases, we would hope that the dopamine release would decrease and the patient would improve. So what is the outcome like? And traditionally, the outcome for psychosis and for schizophrenia has been thought to be rather poor. But we did a study called the ESOP study in 3 English cities, and we followed them up for 10 years. Or I always say, when professors say we followed them up, but of course, professors don't follow anybody up. Some junior psychiatrist or PhD student or some other small person does all the work. And so they were followed up for 10 years, and at 10 years, 40% of those who had received a diagnosis of schizophrenia had had no psychotic symptoms for more than 2 years. So that was much better than we expected. 19% of the people with schizophrenia had no psychotic symptoms and were not taking antipsychotics. So half of them are still taking antipsychotics, half of them were not taking antipsychotics. So there are now 3 other long-term studies have come to similar conclusions that about 20% of patients with psychosis can come off antipsychotics and remain well. Australians will know that Pat McGorry and colleagues from Oregon have similar sort of data. So the problem, of course, is can you predict which 20%? And that's not necessarily so easy. Come back to that in the discussion. So I guess the early intervention units were developed in the 1990s in Australia, and then they came to the UK in 2001, and every region in the UK has to have an early intervention unit. So there have now been RCTs of randomizing people to early intervention treatment or to regular treatment, and they have shown clinical and cost benefits as long as the intervention lasts, and that's usually for 2 to 3 years. Now, the Copenhagen study, the OPUS study, is the longest follow-up, and here you can see the data. The blue, dark blue is what happened to the positive psychotic symptoms in the patients who had the experimental early intervention treatment. The yellow is what happened to negative symptoms, and the light blue and the dotted hash is what happened to the people that got treatment as usual. And you can see that there was no doubt that initially psychotic symptoms and negative symptoms did much better in the people who went into the early intervention units. The problem is that the longer you followed them up, the less difference there was. So by 20 years, there was really no difference in the two groups. So people have questioned, does this mean that the early intervention units are a waste of space, a waste of time, or should we persist with them? What is people's view? Any other people from early intervention? Yeah? Have we got another microphone? Yeah, okay.
I was just wondering, Professor Murray, if this early intervention would impact a lot in the resocialization and the beginning of adult life in a way that other dimensions, not the symptoms, but how the person is coping with their lives would be the difference. Thank you.
So it's a very good point that we shouldn't just consider the symptoms, positive or negative, but also the clinical function. And actually, by 20 years, there wasn't any different there either. Dr. Johar, you run an early intervention unit. Do you think basically it's a kind of occupational therapy for you?
I aspire to be that intelligent. I don't run anything, Robin, just like you. Essentially, I think it's a thing in psychiatry, you know, we're I don't know what the Italian version of Cinderella is, but we always get viewed in... She says it's so much better than me. But essentially, we're always squabbling about money, resource allocation, and what I like, and our Australian colleagues can inform me, but when you speak to Pat McGorry, he gets the money from politicians that isn't earmarked for other mental health services. So it's an extra. And when you view it as an extra, you know, the evidence versus treatment as usual is fine. You're not going to get better service level evidence. But if it's extra money and it's helping folks in terms of resources at that level, and it's not taken away.
What about 20 years?
In 20-year outcome, the Opus one's a weird one because the follow-up wasn't great and they did it via register, didn't they, when they were following up? And we got her to come to the journal club. I think the fact that they were even able to follow anyone up was impressive, to be honest. And there's heterogeneity within the population.
So here we have somebody who is running a first episode unit who is reluctant to follow the evidence.
Huge conflict of interest. Well, no. I was the one who got the journal club there. And if you look at it...
They lost a lot of patients in the follow-up.
They did, and you know, you looked at it and it wasn't as clear as anyone would come up with. I think you still need to pay heed to the evidence.
There's
but
somebody else,
service level
there's
intervention.
a lady behind.
Sorry.
So maybe from Australia. From Australia? Yes?
My name's Jackie. I think it depends on the outcome that's important to you. It's possible that you might be giving these people a couple of years of increased quality of life, and maybe that's worth it, even if 20 years down the track it seems not to make a difference.
Yeah. The way I interpret it, somebody else, Marta?
Yes? Somebody you know?
I'm John McGrath, an Australian works in Denmark. I think Marietta Nordentoft should be congratulated for being a slave to the data here. Follow-up of these cases was pretty, and she found the take-home message is treatment, outcome as usual. And the energy and the thoroughness of the treatment, the better funded early psychosis programs, that's the magic ingredient. And remember, Robin, we saw this in the early days of community psychiatry as well. In the early days, the energy and the enthusiasm, the motivation of the staff, when we emptied the psychiatric hospitals, that was potent because they had hope. And I think that's the secret source of early psychosis. And I think Marietta is telling us that if we want long-term optimal outcomes, we need to fund more staff with more energy and more motivation.
Yeah. So, in a sense, the early intervention service has more support and more resources. If you continued to have so much support and resources for the 20 years, would that improve things? Fran, you're very knowledgeable about this area. What's your view?
So the way we incorporate in Brisbane the early psychosis within our rehab stream, and I'm director of our rehab stream on the southern side of Brisbane, the people in early psychosis who don't go into remission come into our mobile intensive rehab team or our residential rehab team. So it's being able to provide that's required at the time, for the time that's needed. The catch-cry for early psychosis was intervene early, intervene well. For rehab, we say stay the distance. Intervene well and stay the distance. And if you have EP within a rehab pathway, then you give those who need it the care they want in a cost-efficient way.
So I think that is the dilemma, that we can make people better in the short term. We really need more resources to keep the support for the long term. And the other point that John is making is it's the enthusiasm of the staff. There is a big meta-analysis also done by a lady from Australia where she showed that she did meta-analysis of all the treatments for psychosis, antipsychotics, antidepressants, CBT, or the biggest and most consistent effect was that all the psychosocial trials produced benefit, no matter what they were. And they realized what is the ingredient. Somebody develops a new treatment. It's usually a very charismatic and enthusiastic 35-year-old. And they do a controlled trial. And what is the controlled trial? Controlled trial is being run by somebody aged 64 who has 1 year to go before he retires. And he would like to be on the golf course, and he spends his time thinking of ways of poisoning the chief executive. So it's the enthusiasm and the drive and the hope that is often brought that makes the difference.
Can I say something?
Yes.
As Samir, I work in I don't run anything as well, but I work in an early intervention service in inner city London, in Lambert. And I think one point of view which actually Maretta did incorporate in her work is patients' opinion on this, apart from what we measure. And I think patients do like being under the care of an early intervention service. And I don't think necessarily it's just about any specific package of care, but is one, as Robin would say, the level of enthusiasm of the staff, the variety, the level of vocational work, or rehab option, the attention on rehoming, social network. I mean, our early intervention service has a cinema group, as a walking group, as well as all the pharmacological and psychological intervention that you can think of is evidence-based. And I think all of these at the time when you're experiencing psychosis or you are re-experiencing psychosis, because sometimes people do relapse within the time with us, is very important. And the other thing is that they get continuity of care. Usually they have somebody who's with them from the time of onset up to when they are discharged. They get the same psychiatrist. Sometimes it's not a good thing to get the same psychiatrist, but they have somebody that they know. At least in our trust, once you get discharged to a general community, or you either get discharged to GP, which happens much more commonly, and our GP have 5 minutes for you. And my GP, if you go to my GP surgery, he has an horrendous poster that says, "We only have 5 minutes for you. I hope you have prepared your question. Make sure you don't take more than this time because the person after you will actually be waiting." I mean, if any of my patients gets near something like this, they will run miles and never come back. And often these are the services they're supposed to continue to provide care, and all the dimension of social occupational obviously is lost, and they are expected to go back into mainstream employment with all the challenges. If they go to a general community service, the way they are today compared to when I trained, they might see their psychiatrist once every 6 months or once a year, which means that, you know, you stay on the same dose of antipsychotic, nobody cares if you're accumulating side effect, weight gain, and so on. And I think all of this has a huge impact on at least functional outcome, if not as well sort of clinical outcome. So I think the resources of early intervention, I think they should be the basic of care. We see early intervention as something exceptional. I think that should be the baseline care rather than something you only get for 2 years or 3 years. And even old psychiatrists like myself work in early intervention. You don't have to be 34 by all means.
I guess old is a relative term. It's a continuum, not a category. So of course, a proportion of patients diagnosed with schizophrenia will end up but not responding to dopamine blockers, and we regard as treatment resistant. And interestingly, the studies that come out of the US suggest about 30% of patients have treatment resistance our ESOP trial, it had a 24%, but there are places where it's a much lower proportion. At Oslo, it's 5%, and similarly in Hong Kong. This rather implies that there's nothing inevitable about what is happening. The question is, why are they doing it so much better in Hong Kong? Or why am I having... But it's because the screen is blocking the... Ah, right, okay. So why do some patients not respond to dopamine blockers? Well, a very clever lady called Arsimi Demjaha went through all the patients in our ESOP study and got some of them back to do PET scans on them to look at their striatal dopamine. And here in the left, you can see the patients with, the left in the sort of pinky are healthy people, and you can see their level of striatal dopamine. In the pale blue in the middle, you can see patients who responded to antipsychotics. So patients who respond to antipsychotics have high striatal dopamine, and of course we block that with dopamine blockers. The patients who don't respond to antipsychotics and are treatment resistant, they don't show this same high. They're in the purple. So they don't seem to have the high dopamine level. So either they had it and then they've got better from it, or they never had a dopaminergic disorder. And she also looked with a lady called Alice Egerton at glutamate. And here is the same. The pink are healthy volunteers. The responders this time had normal glutamate, and it was the non-responders that had the treatment-resistant patients in purple who had the high who had the high glutamate. So the non-responders seem to have lower dopamine, and therefore if you have low dopamine, blocking dopamine doesn't do you any good. It just causes you side effects. At least some of them seem to have increased glutamate. So this is suggesting that there are two types of treatment resistance. The majority of patients were resistant from the onset, and they never really responded very well to antipsychotics, and they particularly seem to have a glutamatergic disorder. But a minority responded initially, but then became resistant. And they had, the ones who had always not responded, they seem to have more neurodevelopmental problems. The ones who responded initially and then became resistant, they seem to accumulate this resistance as the years went by. And one suggestion is that they develop dopamine receptor supersensitivity. And you can see up in the top part of this slide that the dopamine is released, crosses the synapse, and then hits the receptor. And there aren't very many receptors. But if you keep blocking the receptor on the postsynaptic neuron, what happens? The receptor looks around and says, we're not getting enough dopamine. We must upregulate the receptors to have more receptors to scoop up whatever dopamine that there is. So you get many more receptors, and eventually you can't block them all. So the suggestion is that this is dopamine supersensitivity of the receptor is secondary. If you give rats olanzapine or haloperidol, it seems to block dopamine for about 5 or 6 weeks. But after that, it gradually loses its effect. You have to give more haloperidol or olanzapine, and then the effect seems to be again blocking dopamine, but then after another few weeks, it wears off. So this is one suggestion as to why when we see people initially, we just use a tiny dose of a dopamine blocker, maybe 1 milligram of risperidone or 0.5 milligrams of risperidone daily. But after 10 years, we're giving 6 milligrams or 8 milligrams, and it's still not blocking the dopamine sufficiently. So dopamine receptor supersensitivity is one explanation. So why is clozapine more effective for treatment-resistant schizophrenia? You know that it has a huge range of effects as well. It has relatively modest D2 blocking effects, but it has a lot of other effects. And one suggestion is because it has its blockade of dopamine is lesser, this allows the sensitivity to normalize. And the second suggestion is that clozapine has muscarinic effects, cholinergic effects like CAR-XT. If you give clozapine to people, one of the biggest problems that they have is hypersalivation, and that is a cholinergic side effect. So clozapine seems to have quite strong muscarinic effects, like the new drugs like CAR-XT. So this may be one reason. It may be a combination of this ability to normalize the supersensitivity and the muscarinic effects that make clozapine more effective. So what happens if the clozapine doesn't work either? A very clever man called Nayani said if the psychosis persists for a long time, then the persistent abnormal experiences and delusional thinking seem to colonize the mind. So instead of thinking about your holidays and thinking about your family, you're thinking about your delusions and your hallucinations. And he said patients may begin to expect to hear voices, and their expectation may outweigh the actual environmental stimuli. So for example, I have a patient who's actually a doctor that I've been seeing for a very long time, and she only hallucinates when there's a presence of sound. So when she's in her kitchen and her fridge begins to buzz, she hears the buzzing, and then after a little while the buzzing turns into a voice. She expects to hear a voice, so she's to hear if there is a voice there. Similarly, I have another patient, and when he hears a plane in the distance, he hears the drone of the plane, but it comes nearer to him, then he hears the plane begin to speak to him. That the noise of the plane is transformed into a voice. And a very clever psychologist from Yale called Phil Corlett said, hallucinations arise when strong prior beliefs exert an inordinate influence over the inferences we make about our environment, creating perceptions where there are no corresponding stimuli. So when you expect to see something, you may convince yourself that you've seen it, or your brain thinks you've seen it, or you've heard it. Now you will think this may only happen in psychiatric patients. It would never happen to me. So let me show you this next video.
This is the hollow head. Actually at the moment it's a perfectly normal head of Charlie Chaplin, but wait, as it comes round you'll see, or will you, that it's hollow. The back of it coming round now is actually a hollow mask. It appears to rotate in the opposite direction, and amazingly the nose sticks out, although it's actually sticking in. Coming round now is the normal, correct as it were, face, and wait again as it comes round, and you'll see this extraordinary thing like Jekyll and Hyde. Both the noses stick out because it's so unlikely that a nose sticks in that a face is hollow. So you see it as convex, although it's in fact concave, as now, and then it'll become the normal face again, there. And note that as soon as the features appear in the hollow inside, it will look convex, as though it's a normal face almost, though it isn't. As soon as the features appear, there, your brain refuses to see it as hollow simply because...
So, did anybody not see the two faces? No, everybody saw. I have seen this video maybe 50 or more times, and I keep telling my brain, it's a hollow mask. You've seen it lots before. It's not a face. But my brain still says it's a face, because I guess I've had decades and decades of seeing the outside of somebody's face. I've never seen the inside of somebody's face. So we're tricked because we expect to see a face, we see a face. And similarly, the question is, because people expect to hear a voice, they're straining to hear a voice, they hear a voice. The other very interesting theory that's come out this last year is of spurious autobiographical memories. And this is work from Hong Kong, Eric Chen. And he says, during acute psychosis, this produces experiences which are perceived as real, and are therefore registered as autobiographical memories, even though that they are spurious. So you lay down a memory of the delusions or being pursued by the CIA or the police you think are going to kill you. And this is laid down in a period of great salience, so the excess dopamine imprints it on your hippocampus. So similar to other memories, these memories should subsequently undergo assimilation, accommodation, and extinction. You should realize that you were mistaken. But if the memories are not eradicated, then they're not replaced by normal experiences during remission. They may endure, rendering the individual persistently delusional. So this may explain why the longer you are psychotic before you get antipsychotics, the more likely you are to continue to be psychotic, because you've got 6 months of memories of delusions and hallucinations and terrible things happening to you and threats happening to you, instead of 6 months of happy memories. And it may be that your dopamine or even your glutamate levels are normalized, but you have imprinted in your brain a memory of what happened. And it's very difficult to change people's beliefs as what has happened to them in the past. Think of all the people in the United States who seem to believe fervently in Trump. That would it do any good to give them antipsychotics? Maybe worth trying. No, of course it wouldn't. Now, last thing I want to see, when should I be stopping, Marta?
You have 15 minutes.
15 minutes. I tried to stop long before then. So we know risk factors for psychosis. We know, people say schizophrenia is an enigma. We don't know its causes. We do know the causes of schizophrenia. We know that there are genetic factors. We know that obstetric abnormalities. We know that child abuse. We know that drug abuse. We know that migration. All of these factors are adverse life events. All these are component causes, like risk factors, that accumulate and drive people into psychosis. And all of these things have been shown to impact on dopamine. So it's like for coronary artery disease. All the risk factors for coronary artery disease, hypertension, familial hyperlipidemia, smoking, taking no exercise, they all narrow down eventually on the clot in the coronary artery. And similarly, the risk factors for psychosis all eventually narrow down on the dopaminergic abnormality. Now, the problem, what we do generally in psychosis, is that we treat the psychosis. We don't treat the causes. So the final point I wanted to make, that really it's once you start using an antipsychotic, that's the start of your treatment. It's not the end of your treatment, because you have to say, well, why did they have a dopaminergic abnormality? And there are these various ways, whether there's usually a genetic predisposition to schizophrenia or bipolar disorder, and in the middle these tend to merge. The polygenic predisposition merges in schizoaffective disorder. But we know that there is a neurodevelopmental pathway to psychosis, so that babies who are premature or are very hypoxic have an increased risk of psychosis. We know also that babies who have copy number where there's been a mutation and a chunk of DNA has been mutated, and amongst the genes that are lost or damaged are neurodevelopmental genes, then this also can set up a brain which develops in a slightly different way and predisposes to psychosis. And also there's some suggestion that just having a low IQ will increase your risk of psychosis as well. So people who have what I would call a neurodevelopmental type of psychosis have poor premorbid function, often minor physical anomalies or neurological soft signs, brain structural abnormalities, negative symptoms and neuropsychological deficit, and they have a poor outcome with an excess of treatment resistance. So they're a group who need really quite active intervention, and cognitive remediation would be appropriate for this group to try and maximize their cognitive function. Assertive community management. In the UK, we've found that if you give assertive community management to everybody, clever people who are recovered, they hate it. They don't want to see a nurse every week coming along and saying, are you suicidal this week? They want to be able to get on with their life. But poor souls who are not very bright and are not able to negotiate the social services, they do need support and help in the community. And early clozapine would be another useful thing for this group. The other pathway to psychosis, which has been very neglected in the past, is that it is often mediated by social factors which induce depression or anxiety. So there is a social adversity pathway to psychosis, particularly popularized by Jim Van Os and his colleagues in the Netherlands. So childhood trauma, migration. I'm sure you all know this, that if you're in Syria and your family are bombed and half your relatives die, and you decide to try and migrate, you have to fight you have to get into Turkey some way, and then you meet some smugglers and they will steal your money, but you want to try and get in a boat to get to Greece, and the boat nearly sinks. And all of these things traumatize you, and then you get through Europe, and eventually you try and you get to England, across the North Sea, and maybe the first time the French police catch you and take you back, but you try again, and you eventually get to Britain. Wonderful, we're very happy to be here, the promised land. The people don't want you. They say, we've got far too many of you migrants, and they discriminate against migrants. So there's a lot of reasons why migrants are stressed and discriminated against and have increased risk of psychosis. And of course, people who have adverse life events, particularly intrusive life events. So these people go psychotic, but they need their mood disorder treated. They need to have antidepressants often, and very often they need to have CBT. Not everybody believes in CBT. Our next speaker is Dr. Johar. So in this particular group, Samir, would you think worthwhile trying CBT? Who's got the microphone? Marta? Oh, I've got it.
My opinion doesn't matter. There's a Cochrane review, however, I think in the last month or so, and CBT versus treatment as usual for first episode psychosis, and the difference in the PANSS total was 7. However, when you take the outlier out, which is a pretty clear outlier, it comes to about 3 on the PANSS total. And for those of you who've struggled through the PANSS, I wouldn't say, I wouldn't bet my mortgage on a PANSS change of 3 having a clinically significant difference. But at an individual level, if someone's got a thoughtful person looking after their care, I've got no problems with that. I've just got a problem with, I guess, people mandating something when the evidence isn't as good as we'd like it to be.
In Britain, the so-called NICE guidelines say that all first episode patients have to have the offer of CBT. And Samir is right that the trials don't generally show a big effect. But I still believe it. And my explanation is that a dopamine blocker is a dopamine blocker in Sweden or Denmark or Italy or London. But CBT is very different. And it's the quality of the CBT. So I think we are very lucky that we have very skilled people. Of course, there's also the question, how good is the standard care? If your standard care are very thoughtful and supportive psychiatrists who can stay with you in the long term, then this addition of CBT may not be very good. But if your local psychiatrists are overwhelmed and can only see you for 5 minutes and say, you're still hearing the voices, yes, we better increase your medication, then CBT is going to help these people. So Marta, you're about to say something.
Yes, I'm about to elegantly disagree with both you and Samir for 2 reasons. One,
elegantly?
Yes, meaning I'm not going to argue.
But
okay. I'm going to say, I think the Cochrane review is the Cochrane review, and the evidence are the one that obviously Samir describes. But first of all, here you're talking about not just I mean, what are we talking about CBT about? You can have CBT for trauma. Now, CBT for trauma is not general CBT, which is mandatory for early intervention in the NICE guideline. People who have, for instance, experienced traumatic life events will get trauma therapy. Therapies that deliver that are highly specialized. And you can say that there are international guidelines for the training of psychologists that will deliver psychological intervention. So if we are talking about dealing with anxiety and depression in the context of a first episode of psychosis, which is very relevant, I think that's mandatory. If we're talking about people who are highly specialized CBT psychologists who work with delusion and hallucination or with trauma, I think that's a different class. And then I would like to see an equal level of review done of the not many studies of this type of evidence. And the other thing I would like to say, we tend to say as psychiatrists, a dopamine blockade is a dopamine blockade, but we don't prescribe all in the same way. The same dopamine blockade can be prescribed sensibly, monitored sensibly, or some of us can do it in a way where we might cause more harm than not. So I don't think we can necessarily say that when you look, if you look at trials, I agree, but when you look at practice, I think we're still dealing with colleagues which can be as highly trained and competent.
So I suppose my way of reconciling the Cochrane review with my personal experience is that people with a neurodevelopmental problem are probably not going to benefit greatly from sophisticated CBT, but they might benefit from cognitive remediation. And similarly, people who are drug abusers, they're not necessarily going to benefit from people talking about their trauma when they were 8 years old. But refugees, so it may be that if we broke down psychosis and applied the psychological treatment more specifically, we would be able to see the effect.
And to be fair about the practice, at least in UK, or I can talk actually about my team, the advantage of this being mandatory is that everybody gets it as an offer. Many of my patients decline it. I think patients know what they like and what is going to help. I have many of patients that say, I do not want psychological intervention. It won't help me. I don't like to talk about my feeling and my emotion, but at least you do give them a chance. And there are some of them. My team is an early intervention where unfortunately we can only have people under our care for 2 years, which to me is a very short window of intervention. But some of them, when you offer it at the very beginning, they don't want it, they're not prepared, it's not the right time. Sometimes you offer it to them a year later, and they actually want to deal with the anxiety and the depression that has followed, for instance, coming to terms with having had a year away with psychosis. They might don't have CBT for delusion, but they might like to have some CBT for the anxiety, or especially the social anxiety that is often residuing following delusion of persecution or paranoia in general. So I think the fact that it's mandatory puts us in a position where we need to have the resources to offer it to everybody.
Yeah. So the final big group, I would say, are the drug abuse group. And you will know that this is the fastest increasing component of psychosis, and that there are many places in the world where the incidence of psychosis and schizophrenia-like psychosis is now increasing because of drug abuse. So there's amphetamine psychosis, methamphetamine. In London, cannabis psychosis is the main problem, but the drug-using psychotics, half of whom will develop schizophrenia within 5 years, tend to have higher premorbid IQ, better premorbid function. Diego Quattroni has done a good study on this. Earlier onset, more positive symptoms, fewer negative symptoms, and worse outcome if they continue using. And so we need to actively treat these people. And in our trust, when we call, for some silly reason in Britain, we call psychiatric services trusts. You know, like the Democratic Republic of Congo. Democratic. Would you trust our services? It's unclear, but we call them trusts. Anyway, in our trust, Marta has set up the first clinic for drug-induced psychosis. I guess Australians will be very familiar with methamphetamine psychosis, I guess. Do you still see a lot of methamphetamine psychosis? Still increasing or decreasing? Going up.
We're seeing it in South London.
South London also. Anybody, any North Americans here? No, North Americans maybe booked but went on a cruise instead. No, I don't think we have. But I think methamphetamine psychosis has swept Thailand and Taiwan and the Philippines, South Africa, Australia, has got to the west coast of America, has been coming eastwards and is now reaching Europe. And of course, it's a very nasty illness. This is a study we did 20 years ago, or rather Dr. Chen did. And if you didn't know that people were taking methamphetamine, you would think this was schizophrenia. Oh, so there's the places that it spread to across the world. If one of the great benefits of coming to Palermo is that you're less likely to meet a psychotic person in the street than if you went to London or Amsterdam or Paris. So this is a very stringent study that we did across Europe, and it showed that the incidence of psychosis is 61 per 100,000 in London, 47 per 100,000 in Amsterdam, 44 per 100,000 in Paris, 6.3 per 100,000 in Santiago, and 11.2% in Palermo. So do you want to say your usual risk?
You're giving it away. I can't say now. It's like when people say, do you want to say your usual joke? Of course, it's done. I usually say, because we all know that women have a second peak of onset later in life, that I wasn't very smart to move from a place where the incidence is only 11.2 to one where it's 61.6, given that I'm still in line for potential psychosis onset. So far I've done okay though.
Yeah, okay so far, but more at risk. So the interesting thing is in Northern Europe, the big cities had higher incidence than country areas. So for example, London had a much higher incidence than Cambridge, Amsterdam had a much higher incidence than Leiden, and Paris had a much higher incidence than a rural area called Clermont-Ferrand. This wasn't the case in Southern Europe. Madrid was 24 per 100,000, Barcelona was 12 per 100,000, and Palermo is a bigger place than Verona and Bologna. So what protects Southern Europeans from psychosis that we in the North don't have? The Pope, exactly, yes. So do you think, is it always the Pope or just the new Pope? Anyway, it's not totally a joke, because there are families, and there's now a lot of evidence that solitariness and the loneliness increases the risk of psychosis. But the other question would be cannabis, because at this time cannabis high potency cannabis had not reached Palermo, and you can see in the grey is the adjusted incidence. We've taken out migrants, and you can see in the black the daily use of cannabis. And you can see that daily use of cannabis tracks the incidence of psychosis. So places with a high incidence of psychosis have high consumption of cannabis. Places like Palermo, which have low consumption of cannabis, have low incidence of psychosis. And there's, of course, a lot of evidence that cannabis can induce psychosis. But just to show you that we can trick you, think of another substance that might vary across Europe, and we could see whether it varies with psychosis. Very nice substance. Actually, I've mentioned it already today. It's ice cream. So we can look at ice cream. Now here, this is Mr. Franco, the ice cream man, to whom we are grateful for arranging this beautiful venue. And this is, in the grey, is the frequency of psychosis, and in the black is the frequency of daily ice cream. And you can see that very few people take daily ice cream in London, but it gradually rises to over 50% in Palermo, because Palermo ice cream is fantastic. So some of you may still be prescribing antipsychotics. No, you see, but at least, I mean, this is an artifact, but we do know that...
No, these are real data. What do you mean an artifact?
Okay, this is a real thing. Anyway, so you need to get people to stop using cannabis and set up clinics like the one that Marta has set. So this is Marta's clinic. You can see on the left, people using cannabis, their heads are full of cannabis, they're miserable and solitary, they're hearing voices. They come to the cannabis clinic. See, look what they look like afterwards. They're so much better. Their heads are clear of cannabis. They've taken up music. They're playing the guitar. They're reading. They're cycling about, and they've got a girlfriend. It's a fantastic clinic. Or no, anyway, some of them get some of these because some of them do very well. These people are worth a big investment if you can stop them using drugs. So our job, once we treat psychosis with D2 blockers, is only the beginning. We need to treat the multiple causes of psychosis. And I will get thrown off the podium if I don't stop. Okay, thank you for listening.